Hey everybody, this is Dr. Kareem Godil. Welcome back to the channel. Hope you guys are enjoying the content so far. Today we'll be talking about shock. It's part of our Better Clinician series. Really didn't learn this in medical school, but it's something that you see a lot in the wards and on the floors. So the way that I learned shock was by my seniors who are now pulmonary critical care fellows. They taught it to me in a kind of a special way that I'm going to be teaching it to you guys. So hopefully it is easy to understand, and let's get on with it. Alright, so we're going to be talking about shock. The way that I'm going to be breaking down is first we'll go over the four main categories of shock with a simple explanation. Then kind of what goes inside each of these four main categories in terms of differentials. Then our physical exam findings, a small section about SVO2, and then after that we'll be talking about treatment options. So to break it down, the first one we're going to be talking about is cardiogenic shock. The second one will be distributive. The third one is going to be our obstructive shock. And our fourth one here is going to be hypovolemic shock. Okay, so the first question that we're going to want to answer is why. What? What are these in particular? What happens? Why is cardiogenic shock a thing? What's the physiology or pathophysiology of these? So in cardiogenic shock is basically a low cardiac output. Your heart is not pumping, and if you cannot pump, you cannot fill your vital organs full of blood. That's called cardiogenic shock. What about in distributive shock? In distributive shock, you have massive venodilation. So you have massive venodilation. Basically what happens is your veins, your venules and capillaries and your peripheral arteries start to expand a lot. There's a lot of inflammatory cytokines in the bloodstream, causes massive venodilation. So basically all of your fluid and all of your blood is going to be soaked up in your veins, and it's not going to be able to, and your heart's not going to be able to pump. Obstructive shock is fairly self-explanatory. You have some sort of obstruction blocking the flow of blood from one side to the next side, causing shock. And then the last time, hypovolemic, is also fairly self-explanatory. There's no fluids. If there's no fluids, then there is nowhere for the blood to go because there is no blood. So let's talk about our differentials. Our differentials in each are going to be fairly simple here. What causes cardiogenic shock? So it's going to be MIs, heart failure. You can have valvular abnormalities, such as acute MR or MS, severe aortic stenosis, and arrhythmias can cause cardiogenic shock. What about for distributive shock? This is where we see our sepsis. So septic shock is not a type of shock. It's a subspecies of distributive shock. You can also have vasogenic shock here, neuroplegic shock as well. A lot of different types of distributive shock, and there's many more different types of shock that we'll be talking about. However, we're just going to go over the most common. Then how about for obstructive shock? What are going to be our differentials? This is where you see your pneumothoraxes, your tension pneumos, your PEs, tamponade will be here. And then in hypovolemic shock, this is where you have severe volume loss and hemorrhages. If you have diabetes insipidus and you just pee a lot, so like polyuria / diuresis, or if you have a GI bug and you're having explosive diarrhea or anything like that, can cause hypovolemic shock. So this is kind of our what and our differentials. Next, we're going to go here onto the next slide, and we'll go over our physical exam findings for each. And the important thing to remember in the physical exam findings is going to be our pertinent positives and pertinent negatives. Pertinent positives are going to be things that we do see on the physical exam finding, and our pertinent negatives are going to be things we do not see. This kind of goes to a topic in medicine called likelihood ratios. In likelihood ratios, it's a totally other topic, but it basically tells you how likely are you to have this particular disease. So in cardiogenic shock, things that we look out for are going to be crackles on examination. We're going to be looking for a JVD, jugular venous distension, and we're going to be looking for cold extremities. There are going to be other different types of physical exams that you can find. However, in the scenario that we're talking about, which is shock, we're going to assume that the patient is intubated, so you cannot get a history. And a lot of the other findings that you will see, for example, lower extremity edema, is a non-specific sign. And we can't just go off of that. These three signs in particular are very specific, and if you have the combination, the likelihood ratio increases drastically. So in distributive shock, you will not see any crackles. You will not see any JVD, and your extremities are going to be warm. And at the very end, we'll kind of go over why you have warm or cold extremities. In obstructive shock, you should not have any crackles. You will have JVD, and you will have cold extremities. And then hypovolemic shock, there's no fluid, so you're not going to have any crackles. You're not going to have any JVD, and you are going to have cold extremities. So I want to talk a little bit about why you see these particular exam findings, why in cardiogenic you see crackles and cold extremities. So in cardiogenic shock that we're talking about here, you see crackles because the heart is not pumping. If the heart's not pumping, you're going to get a backflow of all this fluid from your left ventricle into your lungs, which causes your crackles. So it goes into the lungs here. Then from the lungs, it goes into your SVC, and that's what causes your JVD. And since there's no forward flow of blood, your muscles are going to try to constrict so that the blood can be rerouted to the vital organs, which causes cold extremities. You see this same pattern kind of in hypovolemic shock. We'll kind of jump down, which is why you have cold extremities to save the blood for the vital organs, and there's just no fluid for these two. Obstructive shock, the way that I like to think about obstructive shock is going to be right-sided heart failure. The blood from the right side can't get to the left. If you remember our differential here, pulmonary embolisms, that's in between the right side and left side of the heart. So it causes the right side of the heart to fail, so before the fluid can get to the lungs. So that's why you do see a JVD here, and you also get the cold extremities because there's no forward flow. Distributive shock, all this venodilation that you're having causes warm extremities. All the blood and fluid that you have in your body is being pooled in your lower extremities, which is why you get warm extremities, hot, warm extremities. Since it's in the lower extremities, you're not going to have any JVD, you're not going to have any crackles. This is our physical examination findings that really we can assess in a few minutes, hopefully. And that's kind of the goal, because these patients that are in shock, blood pressure is 70/30, very sick patients, and we want to kind of assess and treat them quickly and accurately. Now we're going to be talking about a topic that is a little bit more complicated. This is not medical student level at this point. It's more resident level, and this is what's called SVO2. Some of you may already know what SVO2 is, some of you may not. Again, this is not going to show up on any board examinations unless if you are in residency. So let's talk a little bit about it. We'll scroll down here, and as you can see, I have this beautiful picture of a heart drawn out. And what I want to point out here in the heart, I have a lot of acronyms here. You have our right atrium, our right ventricle, our left atrium, and our left ventricle, representing the four chambers of our heart. And then this on the left side here, you have your IJ as your internal jugular or subclavian vein. And when they combine, you have the superior vena cava. And on the bottom here, you have your inferior vena cava. The red line here, you have a thin and a thick red line. The thin red line, which goes from your IJ all the way down into your SVC, represents a central catheter, a central line. Central lines can go from your IJ, from your subclavian, or from your inferior vena cava via your femoral vein. They usually end right around the entrance of the right atrium. The thicker red line here represents a Swan-Ganz or PA catheter. This also can come in from your internal jugular, your subclavian, or your IVC, but it goes into your right atrium, right ventricle, and ends up in your pulmonary artery. This is where we would like to measure an SVO2, and I'll kind of go over that in a second. So there's a couple of rules that we have to follow beforehand. The first rule is that you cannot obtain an SVO2 from a central line. Okay? And then the second thing is you must obtain an SVO2 from your Swan-Ganz catheter. Okay? I'm really emphasizing this point. The reason I'm emphasizing this point is if you get the SVO2 from here, either from your IJ or subclavian or from your femoral line via your IVC, your SVO2 is not going to be accurate. The reason it's not going to be accurate is because everything from the SVC, IJ, and subclavian is going to be draining the venous blood from your upper limbs, including your brain, and your IVC, everything below, is going to be draining all of the blood from below the upper limb, so all your lower limb and your vital organs. And your brain in particular, which is going to be up here somewhere, uses a lot of oxygen. So your SVO2 is going to be much lower than normal, and in your IVC, it's going to be a little bit elevated. That's why we want to check it from your pulmonary artery, because that way we get all the blood from the upper limb, all the blood from the lower limb, and also you get the blood that drains into the right atrium via the coronary sinus. All three of these mix in the right ventricle and they shoot out into the pulmonary artery. This is why we want to get our SVO2 from the Swan-Ganz catheter. I hope that makes sense and it's not too complicated, because it's about to get a lot more complicated. So what we need to learn next is what's called an extraction ratio. I hope some of you have heard this term before. If not, it's not a big issue. It's fairly simple in concept. This is basically our SaO2 minus our SVO2. This represents our SaO2 is amount of blood in our amount of oxygen in our blood, and our SVO2 is the amount of oxygen coming back before it gets reoxygenated. This measures how much oxygen is used in one pass. Researchers have found that this extraction ratio is different on different diseases, especially cardiogenic and distributive shock. So how much normally you and me, assuming we are have a normal physiology, use in one pass around? And this is roughly 30%. You know, in our SaO2 is going to be around 100%, and our SVO2 should be right around 70. So that means our extraction ratio is 30%. Okay? I'll be back in a second with a little bit of a drawing to kind of explain this a little bit more and why it's different in different diseases. Okay, now we have a little bit of a drawing here, and let me explain this for you. You have NL, which is normal, so this is regular baseline, you and me. C represents cardiogenic, and D represent distributive, a cardiogenic shock and distributive shock, respectively. So what happens normally, you have our RBCs, which is these red little circles here. They go through our capillaries, which is represented in between these black lines, and they go through the other side. And we have some oxygen exchange, goes out, and we're roughly left with 70% oxygen at our venous side if we were to measure from a Swan-Ganz catheter. In cardiogenic, it's a little bit different, where you have a lot more very constricted vessels. Your muscles are oxygen starved, so you have a lot more oxygen delivery. And what ends up happening at the end of this is that your SVO2 is going to be less than 70%. And in distributive shock, you have massive venodilation. So a lot of your blood is going to be going straight through without being filtered. Some of it will be, but in diseases like septic shock, where your mitochondria cannot even use the oxygen, as you can guess it, the SVO2 is going to be greater than or equal to 70%. This is what SVO2 is. You know, if you want to have the takeaway message, it's going to be this little square here, but everything beforehand is really an explanation about why we obtain our SVO2. So if we scroll back up to the top, for cardiogenic shock, we can fill this in now that our SVO2 is going to be less than 70%. And in distributive shock, it's going to be greater than or equal to 70%. In things like obstructive shock, you're going to get an echo or a CTPE, and you should be able to figure this out without an SVO2. And in hypovolemic, again, you really don't need an SVO2 in this as well. So this is our basic SVO2. Why is all of this necessary to diagnose these conditions? Again, as a reminder, these patients are in shock. They're on the cusp of death. So what you really are doing all of this for is for this right here, treatment of these patients. And in order to understand these treatments, we're going to go down to something that we all learned in step 1, or if you're taking your steps, this is probably one of the most important graphs that I have ever seen in my life, and this is called the Frank-Starling curve. Let me just write that down, the Frank-Starling curve. What these doctors, Frank and Starling, basically figured out is if you check the X and Y axis, our X-axis is preload, or also your left ventricular end diastolic pressure, and Y-axis is your stroke volume or contractility, is that as you give preload, your contractility increases. And if you keep giving preload, eventually it will flatten out. And if you keep going, it'll start to go back down. Okay? So normally, our normal physiologic state is we try to stay here with our cardiac output. This is normal. Okay? In cardiogenic shock, you're very volume overloaded. You have too much fluid in your body. Your actin and myosin are spread too far apart to be contracted, so you're shifted way to the right of this curve. And what happens is your cardiac output drops. And in distributive shock, you have the opposite problem. You have too little fluid. You have all this venodilation. So even though that you have a lot of fluid on you, you have so much venodilation, your heart really isn't seeing any of that fluid. And so your cardiac output is much lower than normal. This is the Frank-Starling curve in a nutshell. And the goal of the Frank-Starling curve, again, is to get everybody into this middle area. So now that we have that concept figured out, let's go back up and try to figure out what our treatment options are. For cardiogenic shock, you're going to want to diurese these patients. And for distributive shock, you're going to want to give fluids. You will hear in the wards and on the floors or in the ICU that, hey, this person should not be diuresed. This patient in cardiogenic shock should not be diuresed because their blood pressure will drop. It will not drop because they are so overloaded. As you decrease the fluid, their contractility will increase, their cardiac output will increase, and their blood pressure will increase. In distributive shock, you give fluids. This is why you have the sepsis protocol of 30 cc's per kilo in septic shock patients. You have to adequately fluid resuscitate these guys. One thing I want to mention here are going to be things, and I'm going to write this in purple to kind of, as a last point here, things like inotropes or pressors. These are nothing but band-aids. They are useful, however, they are not going to fix the problem. A lot of times you'll see in the wards that, hey, I'm going to give this guy some Levofet and their blood pressure will go up, and that's all they do. They don't really get to the treatment options. These are band-aids that are there to buy you time, whereas diuresing or giving fluids will really treat these patients. If we go to obstructive shock, you just have to fix the obstruction. And in hypovolemic shock, you just have to give fluids or blood, depending on the cause. Now, there's a lot more nuances to shock. However, this is a very basic approach. However, it's fairly in-depth. And again, to kind of just go over it, you have our 4 main types of shock, what the basic definition is, and our differentials of causes. We have our physical exam findings that we can honestly do in very quickly, 30 seconds to a minute. If we are unable to figure out which type of shock they are in, from that, we have our SVO2 to help us out. And we have our entire diagram to explain what SVO2 is. And then our treatment options with our Frank-Starling curve in mind, and our little asterisks on inotropes and pressors. I hope you all enjoyed this lecture and you are learning a lot from it. I know this is a little bit longer, but this is a topic that a lot of people have trouble with. If you have any comments, suggestions, or questions, please leave them down below. Hope you all are enjoying, and thank you for listening.